Welcome back to the weekly Neurology Deep Dive. Just a quick reminder up front, this deep dive, like all the others, is purely for educational purposes. We're not sponsored, we don't have any commercial interest, and what you're going to hear is just a high-level summary. If you want the full picture, there's no substitute for reading the original paper. So, today's deep dive is all about PET imaging for brain metastases. We'll be focusing on how you can use this in your everyday practice as a neurologist.
All right, sounds good. The data we're looking at comes from a joint practice guideline. It's a hefty one, put together by, well, quite a few organizations, actually.
Yeah.
We got the European Association of Nuclear Medicine. We have the Society of Nuclear Medicine and Molecular Imaging. Then there's the European Association of Neuro-Oncology.
Yeah.
And finally, the PE Task Force of the Response Assessment and Neuro-Oncology Working Group.
Quite the collaboration.
Yeah, they all got together on this one.
So I guess before we dive into the specifics of PET imaging, let's take a step back and remind ourselves why brain metastases are such a big deal for neurologists.
Oh, they're a huge deal. They're actually the most common malignant CNS tumor we see. Way more common than primary brain tumors.
Like, by how much?
We're talking up to 10 times more frequent. And if you look at all cancer cases, brain metastases show up in about, let's say, 9 to 10% of them.
So pretty significant numbers there. And where are these metastases typically coming from?
Most often, the primary source is lung cancer. That accounts for something like 40–50% of cases. Then you've got breast cancer, which is about 15 to 20%. And then melanoma comes in at 5 to 20%.
That lines up with what I see in my practice, for sure. All right, so we know brain metastases are common. What's the main challenge we're trying to address with PET imaging?
Well, the big one, the one that keeps us up at night, is distinguishing between a true recurrence of brain metastasis and, changes in the brain that are just a result of the treatment we've given. And with conventional MRI, that distinction can be, well, a little tricky.
Yeah, sometimes it's a real head-scratcher. So that's where PET steps in. Can you walk us through the main aim of this guideline in terms of PET imaging?
It's all about giving nuclear medicine physicians better tools. This guideline aims to improve how they recommend PT, how they actually perform the scans, and how they interpret and report the findings, specifically for patients with brain metastases. Ultimately, it's about harmonizing practices, making sure things are done in a similar way across different centers, which can help with research, and just making sure everyone's on the same page.
Sounds like a plan. So let's dive into the nitty-gritty. When should we even consider PT imaging in the first place?
I mean, the primary reason, the big indication, is what we just talked about. Differentiating between a recurrence of a brain metastasis and those pesky treatment-related changes. That's the key question that really influences how we're going to manage these patients.
Amino acid PT seems to be the go-to imaging modality here.
Right, you are. Amino acid PET is generally applicable. I mean, we can use it regardless of where the primary cancer came from. It's been extensively used and studied in lung, breast, and melanoma brain metastases. But there's a but there, of course. The evidence base is a bit thinner for other tumor types. And you got to be a bit cautious with certain subtypes. For example, adenocarcinomas might not show as much uptake compared to squamous cell carcinoma metastases. It all comes down to something called LAT1 expression.
LAT1, what's that?
It's a transporter protein. It plays a big role in how these amino acids get taken up by the tumor cells. And, oh, one more thing, mucinous tumors. Those can also be tricky. They sometimes have lower uptake as well.
So basically, amino acid PE is good, but there are some caveats depending on the primary tumor type.
Got it. Now, what if we're dealing with really small metastases, say less than 10 millimeters?
Yeah, that's an interesting point. For those tiny ones, PET imaging might not be as useful, especially when you have high-resolution MRI available. But what if, for some reason, we can't do an MRI? Or what if the CT findings are unclear? Could PT still play a role?
Well, yeah, in those scenarios, it might still be worth considering, especially if you're really struggling to figure out what's going on. But in general, for those smaller metastases, MRI is still the gold standard.
All right, so let's talk about FDG-PET. Where does it fit into this whole brain metastasis picture?
Well, FDG-PET, it's a bit trickier. Generally, it doesn't perform as well as amino acid PET when it comes to separating recurrence from those treatment-related changes. And the reason for that is, well, the brain loves FDG.
The brain loves FDG.
Yeah, the brain's gray matter naturally takes up a lot of FDG. So that makes it harder to see a clear difference between, metastasis and just normal brain tissue. It's all about contrast.
So not the first choice then?
Not usually, no. But there are some situations where FDG-PET might still be useful. For instance, if amino acid PET isn't available for whatever reason. Or let's say you suspect a recurrence in an area that's been irradiated before.
Okay, why would that matter?
Because the radiation can sometimes lower the FDG uptake in the surrounding tissue. So it might actually improve the contrast, making it easier to spot a recurrence.
Interesting.
And then there's some primary cancers that are known to have high FDG uptake. In those cases, FDG PET might be a reasonable option. But you have to be mindful of the flip side. There are also some primary cancers like mucinous adenocarcinoma, lobular breast cancer, and renal cell carcinoma that typically have low FDG uptake. So if the metastasis is from one of those, it might not show up very well on FDG PET. You might even see a cold spot if the metastasis is large enough.
A cold spot meaning?
Meaning an area of lower FDG uptake compared to the surrounding tissue.
Got it. Now, one more scenario I want to run by you. What about using FDG PET as part of a whole body scan when we don't know where the primary cancer is, but we suspect there might be brain metastases? Is that a good idea?
Honestly, not really. The guidelines suggest that routinely adding brain imaging to a whole body FDG PT-CT, just on the off chance there might be brain metastases, isn't super helpful. If you're really suspicious, the best approach is to go for a dedicated brain MRI. Or, if you can't do an MRI for some reason, then a CT scan.
So no shortcuts there. All right, now, beyond this whole recurrence versus treatment-related changes question, are there any other ways we might use PTT in the management of brain metastases?
Oh, absolutely. While the data is still coming in, amino acid PT shows promise for a few other things. It could be used to guide biopsies, help us target the areas with the highest concentration of tumor cells. It can also be useful for radiotherapy planning. And then there's the whole world of disease monitoring and treatment response assessment, especially with these newer targeted therapies and immunotherapy.
How so?
Well, with these therapies, it can be tricky to figure out if the tumor is truly growing or if we're seeing something called pseudoprogression. PTT, especially amino acid PET, could help us make that distinction. There was this one study, actually, where they used FT-PATE.
FPET?
Yeah, that's one of the amino acid tracers. It stands for O2-18-fluorethyl L-tyrosine. Anyway, they looked at patients who were on immunotherapy or targeted therapy, and they found that if a patient had a good metabolic response on FET-PET, meaning the tumor-to-background ratio went down by at least 10%, that was actually pretty accurate, like 82% accurate in predicting that they'd have a longer period of stable disease.
So definitely some exciting potential applications there. Okay, let's shift gears a bit and talk about contraindications. What are the red flags we need to be aware of when thinking about ordering a PET scan?
Okay, so we have relative contraindications, right?
Yeah.
Pregnancy, always a consideration. Breastfeeding is another one. If the mom's received a fluorine-labeled tracer, like most of the ones we've talked about, the recommendation is to pause breastfeeding for about 14 hours. That's roughly 7 half-lives. Got to keep those little ones safe.
Right, of course. What else?
Well, if the patient can't lie still for the whole scan, that's a problem. For a static PT, that might be anywhere from 5 to 20 minutes. For a dynamic amino acid PTT, it could be even longer, like 30 to 50 minutes.
Yeah, that's definitely going to mess up the images.
Absolutely. And then, if we're using a PTMR system, well, any contraindications to MRI are also contraindications to PTMR.
Can you remind us what those MRI contraindications are? The main ones, at least.
So we've got, of course, any history of allergic reaction to MRI contrast agents. That's a big one. Then certain implants, things like pacemakers, defibrillators, cochlear implants, some older aneurysm clips. These things might not be safe in an MRI environment.
So we need to be really careful there.
Absolutely. We need to know exactly what type of implant the patient has, what material it's made of. We often have to dig into the patient's implant card, sometimes even call the manufacturer to be absolutely sure.
Wow, so it's not just a simple yes or no.
No, not at all. Implants are typically categorized as MRI unsafe, which is a hard no. Then there's MRI conditional, which means it might be okay, but only under very specific conditions that we need to carefully assess. And then there's MRI safe, which means we're good to go.
So even if it says MRI conditional, we still need to do our due diligence.
Exactly. We need to make sure all the boxes are ticked.
Yeah.
And then even seemingly small things like metal objects, jewelry, clothing with metal zippers, even dental work, those can sometimes create artifacts on the images.
Artifacts meaning?
Meaning distortions in the images that can make them harder to interpret.
So basically lots of things to consider when it comes to patient safety and image quality.
Lots of things.
All right, let's move on to the radiopharmaceuticals themselves. What are the options for imaging brain metastases?
Well, we've got two main categories. The first is amino acid radiotracers. We've already talked about FPET, but there are a few others.
Like what?
There's FDOPA, which stands for 6-18-fluoroL-dopa. There's MET, or methyl-11C methionine. And there's fluciclovine, which is a mouthful, but it's officially anti-1-meno-3-18-fluorocyclobutane-1 carboxylic acid.
Yikes, that's a tongue twister.
It is.
Okay, and what's the second category?
The second category is the glucose analog radiotracers. The main one here is FDG, which we've already talked a bit about. That stands for 2-deoxy-2-18-fluoro-D-glucose.
Okay, now when we're actually doing these scans, what are the typical doses we're giving to adult patients?
It varies a bit depending on the tracer. For FT, it's usually between 185 and 200 MBq. For FDOP, it's the same, 185 to 200 MBq. Mid is a little higher, typically 370 to 555 MBq. Fluciclovine is usually around 370 MBq, although there are some newer studies on brain metastases where they're using lower doses between 185 and 200 MBq, and then for FDG, it's usually at 185 to 200 MBq.
And for kids, we adjust the dose based on their weight.
Absolutely. We always follow the EANM and SNMMI guidelines for pediatric dosing safety first.
So lots of different tracers, different doses. What are the essential things we need to do to prepare our patients for a brain metastasis PET scan?
Oh, there's a whole checklist. First off, we need a clear clinical question. What are we trying to answer with this scan? That's going to guide everything else.
Makes sense.
Then we need to think about the patient themselves. Can they cooperate? Can they lie still for the whole scan? Do they need someone to help them?
Yeah, got to consider those practical aspects.
Absolutely. And then, critically, we need a detailed history of any prior treatment. Surgery, radiotherapy, systemic therapies. All of that can impact how we interpret the PET images.
Why is that?
Because those treatments can cause inflammation, and inflammation can mimic tumor activity on a PET scan.
Oh, so we could get false positives.
Exactly. That's why the guidelines recommend waiting at least 1 month after radiotherapy or surgery before doing a PET scan.
Okay, so minimize that inflammation. What else?
We need to gather any relevant results. Biopsy reports, resection reports, that kind of thing. And of course, recent MRI scans. We need all the sequences. T1 weighted with and without contrast, FLAIR-R, T2 weighted, diffusion weighted, perfusion weighted, the whole shebang.
And why is it so important to have those MRI scans?
Because we need to compare them to the PT images. It helps us correlate the findings and make a more informed interpretation.
Right, okay.
And then we need to be aware of any recent seizures.
Seizures?
Yeah, epileptic seizures. Those can cause a temporary increase in amino acid uptake in the brain, and that can, you guessed it, lead to false positives on an amino acid PET scan.
So, lots of potential confounders.
There are.
Okay, what else do we need to do to prep our patients?
Well, we need to explain the procedure to them, get their consent, document their weight. That's important for calculating SUV, which is short for standardized uptake value. And then there's the whole fasting thing.
Fasting for a brain scan.
Yeah, it matters. For amino acid PET, they need to fast for at least 4 hours. For FDG PET, it's 6 hours.
Okay, why is that?
Because if they've recently eaten, it can affect the uptake of the tracer. Especially for FDG PT, blood sugar levels are really important. If their blood glucose is too high, we might need to postpone the scan.
Okay, how high is too high?
We usually aim for a blood glucose below 160 milligrams per deciliter, or 8.9 millimoles per liter. And even if we could quickly lower their blood sugar with insulin, it wouldn't really help the image quality. FDG needs a bit of time to reach a steady state.
Got it. So fasting is key. What else?
Oh, for FDG scans, patients should know that we might do delayed imaging.
Delayed imaging.
Yeah, that means taking another set of images 3 to 5 hours after the injection. It helped to improve the contrast between the tumor and the surrounding brain tissue.
So they might need to hang out in the department for a while.
They might. And then there's sedation. If we need to sedate the patient for an amino acid PET scan, we do it 20 to 60 minutes before injecting the tracer.
What before?
Because we don't want the sedation to mess with the tracer uptake. For FDG, it's the opposite. We sedate them as close to the start of the scan as possible, around 30 minutes after the injection. And just one more thing. Carbidopa isn't needed before an FDOPA scan.
Good to know. That's quite the prep list.
It is.
All right, let's move on to the actual PE acquisition protocols. What are the key things we need to be thinking about there?
Well, generally, we're just imaging the head. No need to scan the whole body unless there's a specific reason to.
Okay.
And we need to be super vigilant about movement. Any movement during the scan can really mess up the images. So we're constantly monitoring the patient, especially if they've had seizures related to their brain metastases.
Makes sense.
Now, if we are doing a whole-body FDG, PT, CT, let's say for staging purposes, there's a specific order we follow. We do the whole body acquisition first, and then we do a separate dedicated head acquisition.
Yeah.
That gives us the best contrast for the brain images.
Okay, so two separate scans.
Exactly. And positioning is really important. For head scans, we use a head holder to keep things stable. The arms are usually along the body, and we make sure the neck isn't overly extended or flexed. The field of view needs to include the whole brain, from the top of the cerebrum down to the brainstem and cerebellum.
Got it.
For whole-body FDG scans, the arms are usually up above the head. That helps to reduce artifacts from the torso.
Okay, and I'm guessing keeping the head still is super important for all of these scans?
Absolutely. We use head holders and sometimes even gentle restraints to make sure everything stays in place.
Can you walk us through the specific PET imaging sequences for both amino acid and FDG PET?
Sure. So for amino acid PT, we usually start with a CT scout scan. That helps us get our bearings and plan the rest of the imaging. Then we do attenuation correction. That can be done using CT, a special MRI sequence if we're doing PTMR, or a transmission scan before we inject the tracer.
And what's the purpose of attenuation correction?
It basically accounts for the fact that different tissues in the body absorb radiation differently. This correction is essential to make sure the PE images are quantitatively accurate.
Okay, makes sense.
After attenuation correction, we do the actual PD acquisition. For amino acid PET, that's usually a static acquisition, meaning we're just taking one set of images over a period of 10 to 20 minutes. This usually starts 5 to 20 minutes after the tracer injection, depending on which tracer we're using and how sensitive the PE system is.
Okay.
We can also do dynamic acquisition for amino acid PET, which means taking multiple images over time. That gives us more information about how the tracer is being taken up and washed out of the tissues, which can be helpful for making a diagnosis.
Interesting. And what about FDG PET?
For FDG PT, we typically do a static acquisition that lasts 10 to 20 minutes. But we acquire these images about 60 minutes after the injection. That's the early phase imaging. Sometimes we'll also do delayed imaging, which is acquired 3 to 5 hours after the injection.
And what's the advantage of doing delayed imaging?
It can help to improve the contrast between the tumor and the surrounding brain tissue. Basically, it gives the tracer more time to accumulate in the tumor.
Okay, that makes sense.
And if we're also doing a whole body FDG PET CD, we usually do the body scan first and then the dedicated brain scan.
You mentioned earlier that attenuation correction can be done using different methods. What are the key considerations there?
Yeah, so we can use CT, MRI, or transmission scans for attenuation correction. If we're using CT, they want to keep the radiation dose as low as possible while still getting good quality images. For PTMR, we use MRI sequences for attenuation correction, but we have to be really careful about artifacts.
Artifacts.
Yeah, things like metal implants can cause distortions in the MRI images, which can then mess up the attenuation correction and make the PTT images inaccurate. So we have to make sure the MRI data is really clean.
So we need to carefully screen patients for any metal implants before doing PTMR.
Absolutely. We use a standardized checklist to identify any potential contraindications, and we always check the MRI images very carefully for any signs of artifacts.
Okay, good to know. Now, when we're doing follow-up PT scans, how do we make sure the images are comparable over time?
It's all about consistency. Ideally, we scan the patient on the same PET system using the same acquisition procedures and the same tracer. We also try to use a standardized imaging protocol and interpretation approach so that we're minimizing variability.
Okay, so basically trying to keep everything as similar as possible between scans.
Exactly. And for multi-center clinical trials, it's even more important to be consistent. There are European guidelines that recommend harmonizing the image resolution across all the participating sites so that the data is comparable.
All right, so consistency is key. Now, are there specific recommendations for the timing of image acquisition when using different amino acid PE tracers?
Yes, there are. For PT, we usually do a 20-minute static acquisition, starting 20 minutes after the injection. We can also do a longer dynamic acquisition, which lasts 40 to 50 minutes. If we're doing a dynamic acquisition, we usually use shorter frame durations at the beginning and then gradually increase the duration as the scan goes on.
Why do we do that?
It helps us to better characterize the tracer kinetics, how quickly the tracer is being taken up and washed out of the tissues.
Okay, that makes sense. And what about the other amino acid tracers?
For FDOP, it's usually a 10 to 20-minute static acquisition, starting 10 to 20 minutes after the injection. We can also do a dynamic acquisition, which lasts 30 to 40 minutes.
Okay.
For MED-D, it's typically a 20-minute static acquisition, starting 10 minutes after the injection. We can also do a dynamic acquisition, which lasts about 35 minutes. And for fluciclovine, it's usually a 10-minute static acquisition, starting at least 10 minutes after the injection.
Okay, so there's some variability there, but the general principle is to acquire the images when the tracer uptake has reached a stable level.
Exactly.
And what if the patient is moving during the scan?
If we're expecting movement, we can acquire the static imaging window dynamically using shorter frame durations like 5 minutes, or we can acquire the data in list mode and then reconstruct only the motion-free periods.
Okay, so there are ways to work around that.
There are.
And what about the timing for FDG image acquisition?
For FTG, it's typically a 10 to 20-minute static acquisition acquired 60 minutes after the injection. That's for the early phase images. Sometimes we also do delayed imaging, which is acquired 3 to 5 hours after the injection.
Okay, and we already talked about the rationale for delayed imaging.
We did.
Okay, so last but not least, let's talk about PET image reconstruction. What are the key considerations there?
Well, we need to apply all the necessary corrections. Attenuation correction, scatter correction, randoms correction, dead time correction, decay correction, normalization. It's a whole lot of corrections, but they're all important to make sure the images are accurate.
Okay, so basically a lot of behind-the-scenes processing to make sure the images are as good as they can be.
Exactly. And we usually use iterative reconstruction algorithms, which tend to produce better images than the older filtered back projection methods. Sometimes we also use resolution modeling, which can improve the sharpness of the images. But we have to be careful because it can also introduce artifacts and sometimes affect the quantitative accuracy.
Okay, so we need to use it judiciously.
We do. And for brain imaging, we always aim for high spatial resolution. So the voxel size is usually 1 to 2 millimeters, and the reconstructed spatial resolution is less than 6 millimeters. There are guidelines from EARL, the European Association of Nuclear Medicine Research, LTD, for assessing image quality, and we're hoping to see dedicated guidelines specifically for brain oncology PD imaging in the future.
All right, so we've covered the acquisition and reconstruction. Now let's move on to interpretation. How do we actually make sense of these PE images?
Well, first we need to look at them. And we do that using a computer with special software. We usually display the images with a minimum of 16-bit pixel depth, and we adjust the scaling and color map to optimize visualization.
Okay.
We look at the images in the transaxial plane, and we also compare them to the corresponding coronal and sagittal MRI images. We use anatomical landmarks like the intercommissural line to make sure we're oriented correctly.
Okay, so we're basically getting a 3D view of the brain.
Exactly. Now, for amino acid PET, we adjust the color scale so that the uptake in normal brain tissue is in the lower third of the color range. For FDOPia, we sometimes use the uptake in the striatum, which is part of the basal ganglia, to set the upper limit of the color scale. And for fluciclovine, because the background brain uptake is so low, we usually adjust the color scale so that the uptake in the lesion we're interested in sets the maximum.
Okay, so we're tailoring the color scale to the specific tracer we're using.
We are.
And for FDG PET, how do we adjust the color scale?
For FDG, we usually set the maximum of the color scale based on the uptake in healthy brain tissue. But if there's a lesion that has higher uptake than the surrounding brain, then we'll adjust the color scale so that the lesion uptake sets the maximum.
Okay, so we're always trying to optimize the contrast so that we can see the lesions clearly.
Exactly.
Now, once we have the images displayed properly, how do we analyze them?
We use a combination of visual assessment and semi-quantitative measurements. Visual assessment is always the first step, but it's not enough on its own. We need to quantify the uptake as well, especially when we're trying to distinguish between recurrence and treatment-related changes.
Okay, so we need both qualitative and quantitative data.
We do. And for quantification, we usually use tumor-to-background ratios, or TBRs.
CBR.
Yeah, basically we measure the uptake in the lesion and divide it by the uptake in a nearby area of normal brain tissue.
Okay, that makes sense.
For fluciclovine, we actually use SUV instead of TBR. That's because the background brain uptake for fluciclovine is so low that TBR can be unreliable.
Okay, so we're using different metrics depending on the tracer.
We are. And when we're doing the quantification, we always use the standard summation images, and we fuse them with the recent MRI scans. That helps us to correlate the findings.
Okay, so we're putting all the pieces of the puzzle together.
We are. And when we're fusing the PET and MRI images, we can usually rely on the software provided by the vendors, but it's always a good idea to double-check the alignment visually. For amino acid PT, we often use the scalp and nose as landmarks to make sure the images are properly aligned.
All right, now let's get into the specifics of interpreting the different tracers. Starting with amino acid PTT, what are the key things we're looking for?
Well, for FitMet and FDOP, we consider a lesion positive if its uptake is visually higher than the surrounding brain tissue. and we consider it negative if the uptake is low or can't be distinguished from the background.
Okay, so pretty straightforward.
For fluciclovine, it's a bit different. Because the background brain uptake is so low, we can't really use it as a reference. So we might compare the uptake in the lesion to the uptake in other tissues, like the parotid gland.
Okay, and for FDOP, there's this thing called the tumor to striatum ratio, right?
Right. That's basically the ratio of uptake in the lesion to the uptake in the striatum, which is part of the basal ganglia. It can be helpful for assessing whether a lesion is positive or not.
Okay, so different tracers, different reference regions.
Exactly. And when we're looking at the uptake patterns, we also pay attention to whether the uptake is homogeneous or heterogeneous, and we correlate any areas of intense uptake with the MRI findings.
All right, so lots of details to consider during the visual analysis.
There are. Now, for the semi-quantitative analysis, we typically calculate the TBR, which we talked about earlier. For FETI, MET, and FDOPA, we can use either the maximum SUV or the mean SUV in the lesion, divided by the mean SUV in a contralateral region of normal brain tissue.
Okay.
For FDOPA, we can also use the tumor to striatum ratio, or TSR. And for fluciclovine, we usually just use SUV, particularly the maximum SUV.
Okay, so again, different metrics depending on the tracer.
Different metrics. And we can also do dynamic analysis for amino acid PET. That means looking at how the tracer uptake changes over time.
Okay, how do we do that?
We can do it visually, just by looking at the time activity curves, or we can do it semi-quantitatively by measuring things like the time to peak uptake and the slope of the time activity curve.
Okay, and what can we learn from dynamic analysis?
It can help us to differentiate between recurrence and treatment-related changes. For example, a time activity curve that shows constantly increasing uptake over time might be more suggestive of treatment-related changes, whereas a curve that shows an early peak followed by a decrease or a plateau might be more suggestive of recurrence.
Interesting.
And we can do dynamic analysis for all the amino acid tracers, although it's most commonly done for FET.
All right, now let's talk about FDG PET. How do we interpret those scans in the context of brain metastases?
Well, because FDG is taken up by normal brain tissue, the co-registration with MRI is usually pretty easy. And for the visual analysis, we just compare the uptake in the lesion to the uptake in the surrounding brain tissue. We usually use the gray matter as the reference region because it has the highest FDG uptake.
Okay.
We consider a lesion positive if its FDG uptake is equal to or greater than the uptake in the gray matter, and we consider it negative if the uptake is lower. And remember, delayed imaging can be helpful for improving the contrast between the tumor and the background.
Right, we talked about that earlier.
Yeah, I did.
Okay, and what about semi-quantitative analysis for FDG PET?
We usually calculate the maximum lesion to background uptake ratio using either the maximum SUV or the mean SUV in the lesion, divided by the mean SUV in a mirror image region of interest in the contralateral gray matter.
Okay.
And we can also calculate the washout percentage, which is the difference in uptake between the early and delayed images. That can help us to differentiate between recurrence and treatment-related changes.
All right, so lots of ways to analyze FDG-PET data. Now, are there any established cutoff values for these different tracers? Like what TBR or SUV is considered positive?
There are some suggested cutoff values, but they're mostly based on studies in gliomas. For FDT, the suggested TBR cutoff is 1.6. For MET, it's 1.3. And for FDOP, it's 2.0. For fluciclovine, there's a preliminary SUV cutoff of 4.8. These are just suggestions. There's not a lot of data on brain metastases specifically.
Okay, so we need to use our clinical judgment.
We do. And for FDG-PT, there aren't really any established cutoff values.
All right, so let's say we have all the data, we've done the analysis. How do we put it all together and make a diagnosis?
Well, for amino acid PET, the guideline has a table that summarizes the diagnostic performance of different tracers and different methodologies. But the bottom line is that we need to be consistent in our approach. We need to use the same tracer and the same methodology for follow-up scans. And if the findings are ambiguous, we might need to repeat the scan to see how things are changing over time.
Okay.
For FDG-PET, the visual analysis is often enough to make a diagnosis, but we can also use semi-quantitative analysis if needed. And again, delayed imaging can be very helpful.
All right, so we're looking at the uptake patterns, the TBR or